Thank you, Dr. Graylow. It's nice to be here. And hello, everybody. I'm Dr. Evan Lipson from the Bloomberg Kimmel Institute for Cancer Immunotherapy and the Sidney Kimmel Cancer Center here at Johns Hopkins in Baltimore. On behalf of my colleagues, I'd like to thank you for your interest in our study and thank ASCO for including us in this year's press program. Today, I'll be presenting initial results from Relativity 047, a phase 3 global trial that compares relatlimab plus nivolumab versus nivolumab alone for patients with previously untreated, unresectable, or metastatic melanoma. Next slide, please. As Dr. Graylow just indicated, over the last decade or so, drugs that target the immune checkpoints like PD-1 have dramatically improved survival rates for patients with a wide variety of cancers, including melanoma. So to build on this success and to develop novel regimens that are safe and effective, we combined relatlimab, or RELA for short, which blocks another immune checkpoint called LAG-3, with nivolumab, sometimes called Nivo, which blocks PD-1. And although these drugs work through distinct pathways, they have a common goal, which is to unleash an attack by immune T cells against cancer. In support of this approach are results from trials that led up to the current study, in which administration of RELA plus Nivo caused tumors to shrink in some patients with advanced melanoma that had already progressed through anti-PD-1 alone. Next slide, please. Relativity 047 is the first global randomized registrational study to compare RELA plus Nivo to Nivo monotherapy. Trial patients had previously untreated, unresectable, or metastatic melanoma and received either RELA plus Nivo or Nivo alone. The phrase fixed dose combination that you see in the blue box on the slide refers to the preparation of RELA and Nivo in the same medication vial and administered as a single intravenous infusion in order to reduce preparation and infusion times and minimize the risk of administration errors. The study's primary endpoint was progression-free survival, or PFS for short, which is the length of time between starting therapy and either tumor growth or patient death. Of note, changes in tumor size were assessed by a group of independent blinded radiologists. Secondary endpoints on our study included overall survival and objective response rate. I'll note that as of this presentation, both the study sponsor and the trial investigators remain blinded to those outcomes. Next slide, please. The median progression-free survival of patients who received RELA plus Nivo was 10.1 months, which is more than double that of the group that received Nivo alone at 4.6 months. This significant improvement meant that the study met its primary endpoint with a hazard ratio of 0.75 and a p-value of 0.0055. The PFS benefit appeared relatively early in the course of therapy. You can see that the curves separate at 12 weeks, which was when the first on-treatment imaging was performed, and that separation is sustained through the median length of follow-up, which is about 13 months. Next slide, please. In general, treatment-related adverse events that were associated with RELA plus Nivo were manageable and reflected the safety profile that we typically see with immune checkpoint inhibitors. Although the incidence of grade 3 to 4 treatment-related adverse events was higher with the RELA plus Nivo than with Nivo alone, these adverse events occurred at a lower rate than has been observed with other immunotherapy combinations. Treatment-related adverse events that led to discontinuation of trial therapy occurred in 14.6% of patients in the RELA plus Nivo group, compared with 6.7% of patients receiving Nivo alone. Next slide, please. In conclusion, administration of RELA plus Nivo to patients with previously untreated, unresectable, or metastatic melanoma led to a significant improvement in progression-free survival compared with Nivo alone. RELA plus Nivo demonstrated a manageable safety profile with a lower rate of grade 3 or greater treatment-related adverse events relative to other immune checkpoint inhibitor combinations. And our findings demonstrate that Rela plus Nivo is a potential novel treatment option for this patient population. Additionally, and importantly, this is the first phase 3 study to validate inhibition of the LAG3 immune checkpoint as a therapeutic strategy for patients with cancer. And it establishes the LAG3 pathway as the third immune checkpoint pathway in history after CTLA-4 and PD-1, for which blockade appears to have clinical benefit. So I thank you for your attention, and I'd be glad to answer any questions.